This first podcast is on mood disorders. The term mood disorders is actually a blanket term for several conditions which fall under the F30 to F39 of the ICD-10 classification. Depressive episodes, bipolar disorder, and persistent mood disorders will be covered in this podcast. It is important to note also the risk of suicide in depressed patients, but this is covered in another podcast. So first we're going to talk about depressive episodes. The incidence of depressive episodes is between 80 and 200 cases per 100,000, and it is important to remember that it is more common in females, although this could be due to women admitting their depression more than men. Men are also more likely to deal with any depression with alcohol and therefore be diagnosed with substance abuse problems. The average age of onset of a depressive episode is usually in the late 30s, but it is worth noting that depression can present in childhood or indeed at any age. The various features of depressive episodes can be broadly divided into psychological symptoms and biological symptoms. Let's start by talking about the psychological symptoms. The most important of these is obviously a depression of mood, and this is often associated with what we call anhedonia, which is the loss of interest and enjoyment in activities that were previously enjoyed. In addition, there is often reduced energy levels, which can lead to excessive tiredness, together with reduced attention and concentration, which may also be associated with this tiredness. There may be low self-esteem, together with ideas of guilt and worthlessness. All of these factors can lead to a feeling that life is not worth living, and this is termed hopelessness. It is important to elicit this particular feature when taking a psychiatric history, as it is an important risk factor for suicide. Moving on now to the biological features. The most common of these is probably insomnia, which can manifest in a number of ways. There may be a problem in falling asleep, a broken sleep pattern, or what we call early morning waking, which is waking more than 2 hours before the desired or normal time. Other important biological features include a loss of appetite and weight loss. There may also be a diurnal variation in mood, where the patient wakes up feeling very, very depressed, but their mood gradually increases and rises throughout the day. Other less common manifestations include constipation, loss of libido, and amenorrhea. The mental state examination is a particularly useful format to structure your ideas about particular psychiatric disorders. It is therefore useful to try and learn the key headings of the examination as early as possible when learning psychiatry, as you'll find that you'll develop a much better vocabulary for being able to fit the different disease patterns to this framework. So let's go through the most important features to look out for in the depressed patient. To start with, the patient's appearance may be particularly dishevelled, showing signs of lack of self-care. They may also have downturned eyes or a frowning or expressionless face. There may of course also be evidence of weight loss, and their clothes may appear quite baggy. The patient, if the depression is severe enough, may also show psychomotor retardation. Patients suffering from depressive episodes have characteristic speech, which is slow, quiet, monotonous, and often monosyllabic. Their mood is low, and this is identified by both the patient and the observer. The patient may also describe feelings of sadness and hopelessness. Sometimes, however, the patient can feel anxiety or irritability, and this may be due to associated insomnia or low mood indeed. The patient's thoughts are mood congruent, so they're often very pessimistic with feelings of worthlessness and hopelessness. If the depressive episode is severe, suicidal thoughts may also occur, and this should always be asked about separately. Remember that psychosis can occur, and this tends to occur in the very severe group of depressed patients. Cognitive function is often lower due to poor concentration. This may of course be worsened by associated insomnia and preoccupation with pessimistic thoughts. In the elderly, the poor concentration can present as memory loss, and this is often described as pseudo-dementia. It's also important to be aware of other patterns of presentation of a depressive episode. In a depressive stupor, the patient presents as akinetic and mute, even though they are fully conscious. This is a severe form of depression. In masked depression, the patient will present with somatic symptoms, and often there will be associated attention-seeking behaviour from the medical establishment. Finally, in SAD disorder or seasonal affective disorder, a patient will typically have yearly variations in their mood, with the lowest points of their mood occurring during the darker months of the year, such as autumn and winter. This type of depression usually resolves untreated when the spring arrives. Several disorders should importantly be excluded when investigating a patient with depressive symptoms. These include organic disorders, psychoactive substance abuse, and the negative symptoms of schizophrenia. It's important to identify these particular syndromes as they all require different treatment regimes. So let's move on now to talk about the management of depression. There's going to be a separate podcast detailing the specifics of physical and psychological therapies as used in psychiatry. So in this podcast, I'm not going to spend a long time talking about the specifics of individual therapies. In depression, management ultimately depends upon the severity of the condition. If the depression is very severe and the patient is at risk of self-harm, then admission to a psychiatric unit may be required. Otherwise, the patient can usually be managed in an outpatient or community setting. Treatments may broadly be divided into physical and psychosocial. The mainstay of medicated treatments is antidepressants, of which there are several types, and as with all psychiatric medications, there is no real hard or fast rule as to which specific drug should be used. This is specifically the case for depression, as mild or moderate episodes are often managed by both psychiatrists and, of course, in general practice. SSRIs, or selective serotonin reuptake inhibitors, are the first-line treatment in moderately depressed patients. Another first-line treatment, which can be used perhaps if the patient is unresponsive to SSRIs, is venlafaxine. Mirtazapine is also used in patients who require sedation, and if the patient is very severely depressed, then the older TCAs or tricyclic antidepressants are often used instead. Psychotherapies are also used to treat depression in both the inpatient and the outpatient setting. These include cognitive therapy, group therapy, psychoanalytical therapy, and finally family or marital therapy. The prognosis of depressive disorder is better with greater length of follow-up, and it's estimated that the overall relapse rate is 50%, but this is reduced by continuing medication. The other important statistic to remember is that the overall suicide rate is 9%, and this should prompt you to always look in your mental state examination for suicidal risk. So let's move on now to talk about bipolar disorder, which is the other major disorder in the bracket of mood disorders. Bipolar disorder can only be diagnosed with a manic episode. usually a manic episode accompanied with a depressive episode. But remember that the depressive episode need not occur for many years, if at all. If there are recurrent depressive episodes, then this is diagnosed as recurrent depressive disorder until a manic episode occurs, at which point the diagnosis is changed to bipolar disorder. Bipolar disorder tends to affect males and females with equal preponderance. It is estimated that there is a lifetime risk of around 1% for any individual of developing bipolar disorder, and the average age of onset is in the early 20s. As with most psychiatric illness, the etiology of bipolar disorder is multifactorial. Individuals with a family history of bipolar or indeed mood disorders are at a higher risk of developing bipolar disorder, and personality can also predispose an individual to the disorder. Important examples of this are borderline or depressive personality traits. Triggers or precipitants are usually psychosocial factors, such as significant life events or perhaps physical illness, but remember that there may in fact be no trigger at all. Important perpetuating factors include the social situation around the patient, changes in sleep pattern, and important psychoneuroendocrine factors, which are the neurotransmitters and hormones that are released during these episodes. There are several typical features of mania. The patients usually exhibit an elevated mood with increased energy and reduced sleep. These behaviours often affect the patient's life, resulting in overspending, unrealistic projects, and sometimes sexual disinhibition. Due to the preoccupation with grandiose ideas or just the general restlessness that occurs in bipolar, patients may often neglect to eat or look after themselves. Sometimes the patient can be irritable or angry, and this can be because others find it difficult to keep up with their flight of ideas. It's also possible that they may have grandiose delusions in that they believe that others are jealous and trying to hamper their success. Once again, we're going to use the mental state exam as a way of structuring the typical behaviours and thoughts of these patients. In terms of the appearance, the patient may be wearing flamboyant or revealing clothing, though if mania is severe, there may be evidence of neglect. The patient may appear overactive or fidgety. Characteristic speech in mania is described as pressured speech. There is an increased rate, volume, and it is often difficult to interpret what the patient is saying. The mood may be either euphoric or irritable. Thoughts are often those of inflated importance, or what we term grandiose ideas. An example might be that a patient has information or ideas that are sought after by top agencies such as NASA or the CIA. The patient also exhibits flight of ideas, where the patient hops from one topic of conversation to another. The connection between the ideas are made on chance relationships between ideas, verbal association such as alliteration, clang association or rhyming association, or sometimes distraction, where some external stimulus causes a change in idea. The patient may appreciate colours and textures more, or complain of hyperacusis. In severe mania, the patient may have auditory or visual hallucinations, which tend to encourage or reinforce their grandiose ideas. Often voices, for example, will tell the person that they are great, and visual hallucinations may perhaps be of, say, a throne. Manic patients have poor concentration and attention. They often don't have insight during acute episodes, but in hindsight will realise that their behaviour is not normal. And in some cases where the patient has spent thousands of pounds or realise they may have had casual sexual encounters, a depressive episode may then be triggered. Diagnosis is made usually on the history alone, but there are several other conditions to be aware of and to rule out. These include organic disorders, psychoactive substance abuse, schizophrenia, particularly when there are auditory hallucinations associated with mania, agitated depression, severe obsessive-compulsive disorders, and hypomania. Hypomania is described as a mild elevation of mood, increased energy and activity as in mania, though not necessarily to the same extent. There is also an increase in mental and physical efficiency and increased sociability. The patient is more talkative and can be overfamiliar. However, the most important distinction between mania and hypomania is the ability to function, as hypomanic symptoms do not disrupt life, both in work and in social situations. Management of the manic patient usually involves admission during the acute episode. Antipsychotics can be administered as well during this acute episode, particularly if there are psychotic symptoms such as auditory hallucinations. Lithium is given as prophylaxis for mania, and if a patient is resistant to this, then carbamazepine would be a usual second-line agent. ECT, or electroconvulsive therapy, is reserved for treatment of manic stupor, or as a third-line treatment if multiple drugs have failed. Psychosocial management involves educating the family about the patient's condition and possibly starting family therapies. Finally, it is important to be aware of a couple of other conditions in the bracket of mood disorders. These are cyclothymia and dysthymia. Cyclothymia is defined as the persistent instability of mood involving numerous episodes of mild depression and mild elation. These can usually be left untreated, or if needed, can be treated with lithium or psychotherapy. Dysthymia, or depressive neuroses, is a chronic form of depression that does not fulfill the criteria for recurrent depressive episodes. This is usually treated with antidepressants, psychotherapy, and cognitive therapy.